Chapter 5. Future Directions. The Significance of Charismatherapy. The significance of charismatherapy extends across three domains: the field of psychodermatology, the field of clinical psychology, and the practice of cosmetic dermatology. And its contributions to each domain are distinct, complementary, and clinically important. Within psychodermatology, charismatherapy represents the first psychotherapy specifically designed to address the psychological condition that drives appearance management and cosmetic use as a clinical phenomenon. Psychodermatology has established the bidirectional relationship between psychological states and dermatological conditions, and has demonstrated that treating the dermatological dimension of psychocutaneous disorders without addressing the psychological dimension produces inferior clinical outcomes. What psychodermatology has lacked is a named psychotherapy specifically calibrated to the psychological conditions that drive cosmetic dermatology-seeking behavior. A therapy that addresses not the dermatological symptoms of psychocutaneous disorders, but the fear-based psychological condition that drives individuals to seek cosmetic interventions that cannot resolve their underlying distress. Charismatherapy fills this gap by providing the psychological intervention that is the necessary complement to dermatological expertise in the integrated treatment of charismaphobia-driven cosmetic dependency. Within clinical psychology, charismatherapy makes two specific and significant contributions. First, it introduces a clinical construct that has not previously been articulated in psychological literature: the distinction between beauty and attraction as therapeutic targets. By establishing that attraction is age-independent, culturally inclusive, and universally achievable in ways that beauty, as culturally defined, is not, charismatherapy provides both a conceptual framework and a practical therapeutic alternative to the culturally constructed beauty standards that generate charismaphobic anxiety. This distinction is not merely semantic. It has direct and clinically significant implications for how appearance-related psychological distress is conceptualized and treated. Second, charismatherapy introduces the unique feature identification technique as a specific therapeutic method for reversing the charismaphobic cognitive pattern of selective abstraction, the compulsive focus on perceived inadequacies that sustains charismaphobic anxiety. By directing the client's attention toward the distinctive physical features that selective abstraction has rendered invisible, unique feature identification provides a concrete, individually tailored, and clinically actionable technique that can be delivered within a single therapeutic session. Within the practice of cosmetic dermatology, charismatherapy provides practitioners with a named clinical framework and the vocabulary that accompanies it for understanding, communicating about, and appropriately responding to the psychological conditions that drive their clients' cosmetic treatment seeking. The absence of such a framework has left cosmetic dermatologists without the clinical tools needed to distinguish between psychologically healthy cosmetic treatment seeking and charismaphobia-driven cosmetic dependency. A distinction that is not only clinically important but ethically essential, given that offering cosmetic procedures to charismaphobic individuals whose distress cannot be resolved by cosmetic means constitutes a clinical and ethical failure regardless of the technical quality of the procedure performed. Charismatherapy provides practitioners with both the diagnostic framework for making this distinction and the referral pathway for responding to it appropriately. Implications for the cosmetic industry. The cosmetic industry's current relationship with charismaphobia. The cosmetic industry, encompassing cosmetic products, cosmetic procedures, cosmetic surgery, anti-aging treatments, and the media infrastructure that supports and promotes them, occupies a structurally ambiguous ethical position in relation to charismaphobia. On one hand, the industry provides genuine products and services that serve legitimate functions. Cosmetics used for authentic self-expression and creative personal presentation, skincare products that address genuine dermatological conditions, and cosmetic procedures that serve medically justified reconstructive or corrective purposes. On the other hand, the industry's commercial success is structurally dependent on the sustained and escalating fear of unattractiveness that constitutes charismaphobia. Because charismaphobic anxiety, as established throughout this work, is the primary psychological driver of the compulsive, escalating, and medically unjustified cosmetic consumption that generates the industry's most significant revenue streams. The commercial exploitation of charismaphobic anxiety by the cosmetic industry is not incidental or occasional. It is structural and systematic. As Wolff established, beauty standards are deliberately constructed to be unachievable, because an achievable beauty standard would generate a satisfied consumer who no longer needs to purchase beauty products, while an unachievable beauty standard generates a perpetually anxious consumer who must continuously invest in cosmetic interventions that promise but consistently fail to deliver permanent resolution of appearance-related distress. Media's role in constructing and enforcing these standards, promoting anti-aging products with the equation of beauty with youth, presenting digitally edited images as realistic beauty standards, and promoting celebrity idealization as a driver of cosmetic surgery seeking, is the commercial operationalization of this structural dependency on the fear of unattractiveness. The cosmetic industry does not merely respond to pre-existing charismaphobic anxiety. It actively generates, sustains, and intensifies it through the media, marketing, and cultural messaging strategies that constitute its commercial infrastructure. The clinical establishment of charismaphobia as a named, validated, and measurable psychological condition, and the introduction of charismatherapy as its therapeutic treatment, has direct and significant implications for how the cosmetic industry's current practices must be understood and evaluated. When the fear-based motivational structure of cosmetic consumption is clinically established rather than theoretically asserted, the industry's commercial exploitation of that fear can no longer be treated as a morally neutral commercial activity. An industry that knowingly generates and sustains a clinical anxiety condition to sell products and procedures that temporarily relieve the anxiety without resolving the underlying condition is not merely engaging in aggressive marketing. It is causing measurable psychological harm to identifiable individuals for commercial profit. The clinical establishment of charismaphobia as a validated psychological condition therefore raises ethical questions about the cosmetic industry's practices that go beyond the questions of product safety and informed consent that currently constitute the industry's primary ethical framework. What the cosmetic industry must change. The introduction of the charismaphobia framework and charismatherapy creates both an ethical imperative and a practical opportunity for the cosmetic industry to fundamentally reconsider several of its core practices. The first necessary change is in the industry's marketing language and messaging strategy. Cosmetic marketing currently operates through a systematic activation of appearance-related fear and insecurity, presenting idealized and digitally constructed images as realistic beauty standards, framing the natural aging process as a problem requiring cosmetic solution, and positioning cosmetic products and procedures as essential rather than optional components of social acceptability and professional success. This marketing strategy is not merely manipulative in a general sense. It is, in the light of the charismaphobia framework, a direct clinical intervention in the psychological vulnerability of consumers who may already be experiencing charismaphobic anxiety, and whose anxiety the marketing is specifically designed to intensify in order to drive purchase behavior. An industry that is aware of the clinical reality of charismaphobia, and the cosmetic industry cannot now claim ignorance of it, has an ethical responsibility to refrain from marketing strategies that are specifically designed to exploit that clinical vulnerability. Responsible cosmetic marketing would present products as tools for authentic self-expression and genuine self-care, rather than as defenses against the social consequences of unattractiveness, and would refrain from the fear activation messaging that currently constitutes the dominant register of cosmetic advertising. The second necessary change is in the industry's approach to the promotion of cosmetic procedures. The normalization of cosmetic surgery as a routine response to appearance-related anxiety, which Bordeaux identified as a cultural process, and which the data from the earlier study confirmed as a clinical reality in cosmetic dermatology practice, is an industry-driven phenomenon that has direct and measurable clinical consequences. When cosmetic surgery is marketed as a normal, accessible, and psychologically uncomplicated response to appearance dissatisfaction, individuals who would more appropriately be referred for psychological intervention are instead encouraged to seek surgical solutions that cannot address their underlying condition. The industry has a responsibility to ensure that the promotion of cosmetic procedures is accompanied by accurate information about the psychological conditions that contraindicate them, including charismaphobia, body dysmorphic disorder, and related presentations, and that the boundary between cosmetically appropriate and psychologically inappropriate procedure seeking is clearly and honestly communicated rather than deliberately obscured in the interest of commercial volume. The third necessary change concerns the industry's relationship with the practitioners who deliver cosmetic services. The finding that cosmetic dermatologists recommend medically unjustified procedures at a rate of 53.33% is not merely an individual practitioner failure. It reflects a systemic industry environment in which the commercial incentives for procedure recommendation are structurally misaligned with the clinical interests of patients. An industry that profits from the escalation of cosmetic consumption has a structural incentive to create an environment in which practitioners are rewarded for recommending more procedures, rather than for identifying and appropriately responding to the psychological conditions that contraindicate them. Addressing this structural misalignment requires industry-level changes. The development and promotion of assessment protocols that screen for charismaphobia and related psychological conditions as a precondition for cosmetic procedure recommendation. The integration of psychological referral pathways into cosmetic practice as a standard rather than exceptional clinical response. And the recalibration of the commercial incentive structures that currently reward procedure volume over clinical appropriateness. What the cosmetic industry stands to gain. The ethical imperatives outlined above are not only moral obligations, they represent a significant commercial opportunity for an industry whose long-term sustainability is threatened by the very dependency model on which its short-term revenue is currently organized. The charismaphobic consumer, whose cosmetic consumption is driven by fear-based avoidance motivation rather than by approach-motivated aspiration, is not a satisfied customer. The temporary anxiety relief that cosmetic interventions provide does not generate genuine product satisfaction. It generates the return of anxiety and the need for repeat purchase. An industry built on the generation and temporary relief of charismaphobic anxiety is therefore structurally committed to a consumer relationship characterized by compulsion, dissatisfaction, and the continuous escalation of consumption. A relationship that is not only ethically problematic but commercially fragile, because it is dependent on the sustained maintenance of consumer psychological distress rather than on the delivery of genuine consumer value. The charismaphobia framework and charismatherapy offer the cosmetic industry a genuinely alternative commercial model, one organized around the cultivation of genuine holistic attraction and authentic self-expression rather than the management of the fear of unattractiveness. An industry that positions its products and services as tools for authentic self-expression, as enhancements of the genuine, distinctive, and individually specific attraction that every person possesses, rather than as defenses against the social consequences of unattractiveness, is an industry that can build a consumer relationship grounded in positive aspiration, genuine satisfaction, and authentic personal empowerment. Such a consumer relationship is not only ethically superior, it is commercially more sustainable because it generates genuine consumer value rather than merely temporary relief from a fear that the industry itself has generated. Implications for the practices of cosmetic dermatologists and beauticians. The introduction of the charismaphobia framework and charismatherapy has specific, concrete, and clinically actionable implications for the day-to-day practice of the two professional groups who most frequently encounter charismaphobic individuals: cosmetic dermatologists and beauticians. These implications extend beyond the assessment and referral recommendations provided earlier to encompass the fundamental clinical philosophy within which cosmetic practice is conducted, and the specific practice changes that the charismaphobia framework requires. The most fundamental implication is a shift in the clinical question that cosmetic dermatologists and beauticians ask when a client presents with appearance-related concerns. The current default clinical question in cosmetic practice is effectively, what cosmetic intervention does this client need? The charismaphobia framework requires a prior clinical question. Is this client's treatment seeking driven by a genuine medical or aesthetic need, or by charismaphobic anxiety about normal appearance? This prior question is not supplementary to clinical practice, it is foundational to it. A cosmetic dermatologist who recommends a procedure without first establishing the answer to this question has not completed a clinically adequate assessment, regardless of the technical quality of the procedure subsequently performed. The charismaphobia scale, which can be administered in a brief clinical encounter, provides the measurement instrument through which this prior question can be answered with clinical rigor rather than clinical intuition. For cosmetic dermatologists specifically, the charismaphobia framework has implications for the informed consent process that currently governs cosmetic procedure recommendation. Genuine informed consent requires that the patient understands not only the physical risks of the procedure, the adverse effects, complications, and recovery requirements that current informed consent protocols address, but also the psychological risks. Specifically, the risk that if their treatment seeking is charismaphobia-driven, the procedure will not resolve their underlying psychological distress and may intensify cosmetic dependency by negatively reinforcing the belief that cosmetic interventions are the appropriate response to appearance-related anxiety. A charismaphobic patient who consents to a cosmetic procedure without understanding this risk has not given genuinely informed consent. They have consented to a procedure on the basis of a psychological expectation that the procedure will resolve their appearance-related distress, that the clinical evidence of charismaphobia research establishes as systematically false for individuals whose distress is charismaphobia-driven. The charismaphobia framework therefore expands the scope of informed consent in cosmetic practice to include the psychological dimension of procedure-seeking motivation, a dimension that is as clinically relevant as any physical risk factor, and that current practice systematically fails to address. For beauticians, the charismaphobia framework has implications for the nature and boundaries of the quasi-therapeutic relationships that beauty professionals routinely develop with their clients. The finding that 66% of beauticians provide informal psychological guidance to their clients without training reflects both the genuine psychological dimension of the beauty professional relationship and the equally genuine clinical insufficiency of that relationship as a vehicle for addressing charismaphobic psychological distress. Beauticians who understand the charismaphobia framework are better positioned to recognize when their clients' appearance-related concerns have crossed the threshold from healthy cosmetic interest into clinically significant charismaphobic anxiety, and to respond to this recognition not by attempting to provide informal therapeutic support that exceeds their professional competence, but by providing structured psychoeducation about charismaphobia and facilitating referral to appropriately trained psychological practitioners. The longer-term implication of the charismaphobia framework for both professional groups is the development of an integrated model of cosmetic practice in which psychological assessment and referral are structural components of the clinical pathway rather than exceptional responses to obviously disturbed presentations. The integrated psychodermatology model, in which dermatological and psychological expertise are combined within a single clinical setting, has been established as both clinically superior and more cost-effective than treating the dermatological and psychological dimensions of psychocutaneous disorders separately. The charismaphobia framework extends this integrated model to cosmetic practice. The optimal cosmetic clinical pathway is one in which every client presenting with appearance-related concerns receives a brief charismaphobia screening. Those identified as charismaphobia-driven are offered charismatherapy or appropriately referred for psychological intervention. And those whose treatment seeking is genuinely medically or aesthetically motivated receive their cosmetic treatment within a practice environment that is psychologically informed, ethically grounded, and clinically rigorous. This integrated model is not a utopian aspiration. It is a clinically achievable practice standard whose implementation requires training, institutional commitment, and the industry-level changes outlined in the preceding section. But that is practically realizable within the existing infrastructure of cosmetic practice. Limitations. The present work introduces charismatherapy as a charismaphobia-based clinical framework, grounded in 3 foundational empirical studies conducted in Pakistan. Acknowledging the limitations of this foundational research is not a qualification of the framework's theoretical and clinical significance. It is a scientific obligation that identifies the specific empirical gaps that future research must address in order to establish charismatherapy as an evidence-based intervention. The first and most significant limitation is the single country, single cultural context base of the foundational charismaphobia research. The charismaphobia scale was developed and validated with participants from Islamabad and Rawalpindi, Pakistan. A specific cultural context with its own beauty standards, social norms, colorist pressures, and gender dynamics that differ in important respects from the cultural contexts of Western Europe, North America, East Asia, Sub-Saharan Africa, and other world regions. Charismaphobia as a psychological construct is theorized as a universal phenomenon, because the social rewarding of attractiveness and the social penalizing of unattractiveness have been documented across cultures. But the specific content of charismaphobic anxiety, the relative salience of its 4 empirical factors, and the cultural specificity of the beauty standards that generate it will inevitably vary across cultural contexts in ways that the current research base cannot capture. Cross-cultural replication of the charismaphobia scale validation across diverse cultural contexts is therefore the most urgent empirical priority for the charismaphobia research program. The second limitation is the theoretical rather than empirically tested status of charismatherapy itself. The present work introduces charismatherapy as a theoretically grounded clinical framework, establishing its foundations across 7 psychological schools, articulating its 5-phase structure, and specifying its therapeutic goals, but does not provide empirical evidence of its clinical efficacy. The hypotheses advanced later in this chapter include specific predictions about charismatherapy's efficacy, but these predictions are theoretical anticipations rather than empirical findings. Charismatherapy's clinical validity must ultimately be established through the research program outlined in this chapter, including pilot studies, randomized controlled trials, and systematic follow-up assessment, before it can be claimed as an evidence-based intervention rather than a theoretically grounded clinical proposal. The theoretical grounding is substantial, and the clinical rationale is strong, but the empirical validation remains the essential next step. The third limitation is the 5-hour standalone delivery format of charismatherapy, which, while clinically motivated by the realities of cosmetic practice, has not been empirically evaluated against alternative delivery formats. It is possible that a more extended delivery format, involving multiple sessions over several weeks, with between-session behavioral assignments and longitudinal follow-up, would produce superior therapeutic outcomes for some charismaphobic presentations, particularly those involving high anxiety subscale scores, significant comorbid conditions, or deeply entrenched cosmetic dependency patterns. Conversely, it is possible that the 5-hour format is more effective for some presentations precisely because its intensity and self-contained structure prevent the avoidance behaviors and between-session anxiety escalation that more extended formats can generate in highly anxious clients. These delivery format questions can only be resolved through empirical comparison, and future research should include delivery format as a systematic variable in charismatherapy efficacy trials. Future research directions. The charismatherapy framework generates a systematic and comprehensive empirical research opportunity that addresses several distinct levels of scientific inquiry. At the psychometric level, The most urgent priority is the cross-cultural replication and validation of the charismaphobia scale across linguistically, culturally, and demographically diverse populations. Extending beyond the Pakistani context, in which the foundational studies were conducted to establish the scale's generalizability across different beauty standard environments, colorist cultural contexts, and gender role structures. At the structural level, future research should examine the predictive validity of the charismaphobia scale for real-world cosmetic behaviors, including cosmetic expenditure, procedure-seeking frequency, and willingness to undergo cosmetic surgery, while controlling for related constructs and demographic variables. Structural equation modeling studies testing the full proposed architecture of charismaphobia. The self-reinforcing cycle of anxiety, media consumption, beauty standard internalization, and cosmetic use will determine which causal pathways are empirically supported and which require theoretical revision. Studies examining gender, skin tone, body shape, positive body image, and media literacy as moderators of charismaphobic anxiety will further clarify the demographic and contextual conditions under which charismaphobia develops most intensely and under which it is most effectively buffered. Findings with direct implications for both clinical assessment and population-level prevention. At the clinical level, the efficacy of charismatherapy requires systematic investigation of randomized controlled trials against both waitlist control and active comparator conditions, and extending to dismantling studies that identify the specific therapeutic phases responsible for the greatest clinical gains. Long-term follow-up research at 12 and 24 months post-intervention will establish whether a single 5-hour session produces durable protection against charismaphobic relapse, or whether booster sessions are required for sustained therapeutic benefit. Practitioner training research, examining whether cosmetic dermatologists and beauticians trained in the charismatherapy framework demonstrate improved referral practices and reduced medically unjustified procedure recommendation, represents a specific and clinically urgent efficacy objective given the scale of untrained psychological intervention already occurring in cosmetic settings. Beyond the core research program, the charismaphobia field requires engagement from several adjacent disciplines, including neuroscience, social media research, public health, and feminist scholarship, whose contributions are essential for a complete scientific understanding of the condition. Neuroimaging studies of charismaphobic individuals before and after charismatherapy would provide powerful evidence of the intervention's neural impact. Social media algorithm research would clarify the mechanisms through which digital platforms amplify charismaphobic vulnerability. Epidemiological studies would quantify the public health burden of charismaphobia at the population level. Cross-disciplinary collaboration across clinical psychology, psychodermatology, public health, and social media studies is ultimately the research environment in which charismaphobia will achieve its full scientific potential, because it is an inherently interdisciplinary condition that no single discipline can adequately address alone. Chapter summary. This chapter has situated charismatherapy within the broader landscape of professional practice, commercial industry, and scientific inquiry, extending the clinical framework of charismaphobia and charismatherapy into the domains of significance, implication, limitation, and future direction. Charismatherapy's significance extends across psychodermatology, clinical psychology, and cosmetic dermatology, practiced simultaneously, filling the psychological intervention gap that psychodermatology has identified but not resolved, introducing the beauty to attraction distinction and unique feature identification technique to clinical psychology, and providing cosmetic practitioners with the named framework and referral vocabulary that the ethical demands of their clinical position require. The cosmetic industry's current relationship with charismaphobia has been identified as structurally exploitative rather than commercially neutral. With fear activation marketing, the normalization of cosmetic surgery, and the structural rewarding of procedure volume over clinical appropriateness, identified as practices that cause measurable psychological harm to identifiable individuals, and that the clinical establishment of charismaphobia now renders ethically indefensible. For cosmetic practitioners specifically, a foundational shift in clinical question, from cosmetic intervention planning to the ethically prior assessment of whether treatment seeking is driven by genuine need or charismaphobic anxiety, has been established as both clinically necessary and practically achievable through the integrated psychodermatological practice model that the charismaphobia framework makes possible. The chapter has acknowledged honestly that the single-country cultural base of the foundational research, the theoretically rather than empirically established status of charismatherapy's clinical efficacy, and the unevaluated delivery format assumptions of the 5-hour standalone session constitute significant limitations that future research must systematically address.